of our favorite topics, I'm sure. We'll talk about puberty, we'll talk about menstrual cycle, we'll talk about some menstrual cycle disorders. Some of you may have teenage girls or young girls that are going through some of this, and so it kind of allows you to maybe empathize with them a little bit, and understand maybe what these young women go through. So we'll talk about kind of the process and what puts people into puberty, for specifically we're focused on young females, and then all of the hormonal changes that are associated with the menstrual cycle, and then a couple of menstrual disorders, psychological disorders as well. We've got our ELOs and our TLOs, a couple of check-on learning. Remember last week? I guess, that seems like it. Yesterday? When did we meet? Last week? I think it was last week. Yeah, sometime. I agree with you. We really just did a review of anatomy, but we also talked about the presence or absence of a Y chromosome. And if there is no Y chromosome, that means you do not have testes determining factor. And it means that our Müllerian structures, which belong to females, Wolffian structures belong to males, Müllerian structures belong to females. You guys remember the other name for Müllerian structures, those ducts? Are they paramesonephric or mesonephric? Paramesonephric. We talked about we don't have testes determining factor, we don't have inhibition of our Müllerian structures. And Müllerian structures, three things really that we think about: uterus, fallopian tubes, and upper portion of the vagina. So remember, someone can still have the distal portion of the vagina, have intercourse, but not be able to conceive, not have a menstrual cycle, because they may not have the uterus or the structures to do that. Those are Müllerian structures. And then we talked a little bit about VSDs, specifically associated again with females. So I would look over those VSDs. You will see them again on the exam. Understand what lab abnormalities, and it should ultimately kind of make sense if we talk about hypergonadotropic hypogonadism versus hypo. We talk about hypergonadotropism, we're talking about FSH and LH, that is high, because it's hyper. And then the other part of that hypogonadism, that's going to be low estrogen and progesterone. And sometimes those labs are kind of they're kind of normal low, especially for estrogen and progesterone. So you may not have, significantly high FSH and LH, but they're a little on the high end of normal, and it kind of leads you to believe that there's, especially depending on what the patient's complaining of. So kind of understand the lab implications of those DSDs, and of course how these patients can present. We've got a 14-year-old female comes in. She's been diagnosed with primary amenorrhea. We haven't talked about amenorrhea yet, but we will. But essentially, she has not had a menstrual cycle. We talked a little bit about it at the beginning of last lecture, but we'll talk about more today. Ultrasound reveals no uterus. So what is the most likely cause for amenorrhea? Müllerian dysgenesis, right? Turner syndrome. So Turner syndrome, they do typically have a uterus, but they have what they call streak gonads. So the ovaries are there, but very small and non-functional. Imperfect hymen, we talked about that, is these patients may come in with that cyclic abdominal pain, and when we're doing the physical exam, we may see a bluish tinge of the hymen. And normally, women, young females, will have a little hole in their hymen. Sometimes multiple little holes, but that allows the area or place for the menses to escape. If they don't have that, that's imperforate, and they have a uterus, they have an endometrial lining, that endometrial lining is shedding, we just can't see it externally because we have no outflow. Okay? The outflow tract is obstructed. And then Asherman syndrome, another thing we haven't talked about, but Asherman syndrome is scarring within the uterus, and it could, again, obstruct. It's part of an obstruction process that does not allow the menses to come out. So that's Müllerian dysgenesis, the person that does not have a uterus fallopian tube portion of that. We've got to remember about some sexual implications of the peritoneal anatomy. We know that For the pelvic shapes, we think about gynecoid and we think about anthropoid as our most common shapes. Ideally, we would choose a gynecoid pelvis because it's about the shape of a baby's head and it does allow the head to come out pretty easily. If someone has a procipaloid or an android pelvis, that is not good for vaginal delivery. Okay, they're much more flat and wide at the sides, and that's not how a baby's head is designed. Baby's head is not flat and pokes out here, right, like a Marshall might. And so we don't really like those pelvic anatomy. That can happen, especially if someone, so if we think active duty, people jump out of planes, people break their pelvis jumping out of planes, not infrequently, right? So if you have someone that comes in, they're pregnant, they're going to deliver, and they have a history of pelvic fracture, well, they may have been born with a normal pelvis, but then as from that fracture, and then as that fracture is healed, you can get some scar tissue that may have changed the way that their pelvis is. So no, gynecoid and anthropoid, those are our ideal pelvic shapes. And then know that how the uterus lies within the lower abdomen, peritoneal cavity, will depend on what your physical exam might be. It will have clinical implications. If somebody has a retroverted and retroflexed uterus, meaning in general that uterus is sitting in the posterior aspect and the fundus of that uterus is bent posteriorly right towards the rectum, then you're probably not going to be able to feel that fundus on a physical exam, on our bimanual exam. Okay? Sometimes you have to do a rectal exam to feel that. Just to be able to see the cervix, you're going to have to change the angle of your speculum because, again, the uterus is down further, so the cervix is going to be down more posterior in the posterior portion of the pelvis. Okay? So understand those clinical implications. All right. We've got puberty. Let's start off from the very beginning. So puberty is development of those secondary sexual characteristics, and ultimately reproductive capability will start at puberty. We all, I am sure, are aware of young girls, they've had one menstrual cycle and they're pregnant. And so that ultimately can happen once you start having puberty, start having menstrual cycles is the first sign of reproductive capability. Typically, this occurs over a 3-year period of time, and it's measured using the Tanner stages. So this is a pictorial representation of the Tanner stages. So when we think about stage 1, people typically would use age less than 10, could be a little bit younger than that. But there's really no evidence. We don't have any pubic hair, we don't have any breast bud development. So this is all kind of prepubertal time period for stage 1. Stage 2, usually 10 to about 11 and a half, we'll start seeing the development of those breast buds. We're starting to start to see maybe a little bit of axillary hair and some pubic hair, but it's more straight, more coarse axillary hair and pubic hair. Stage 3, 11 and a half to about 13 years old. Now the breasts are starting to allow outside of the, just those breast buds. And then that pubic hair is going to, and the axillary hair is going to start to change. It gets more dark, it's more curly, and a little bit more fine. Okay? And we go all the way up to stage 5, and that is the adult female. We have the full breast bud, or breast development, and then we've got full pubic hair and axillary development. We typically would think about puberty, again, starting around 10 to 11 years old. Okay? Can occur as late as 13 and still be considered normal. In certain ethnic groups, oftentimes Hispanics or African Americans, we can actually have puberty that occur earlier than what we expect. Overweight kids as well. The thought about kids that are overweight is that it relates really specifically to leptin. And leptin is found in astrocytes, so the fat tissue, and it produces estrogen. Okay, so if we have an increase in circulating estrogen, affects the ovaries, also affects the pituitary, hypothalamus. So when we put all of that together, it's going to push these females into puberty a little bit earlier. And this was done on many years ago in a study on mice to try to figure out why, in fact, do some of these overweight females go into puberty earlier. And the biggest thing they identified and why they think it's leptin is because mice that were deficient in leptin did not go into this pubertal sequence, so did not start puberty. So that's kind of the thought behind there of a study that was done many years ago. There are other factors that can certainly affect the onset of puberty. So if mom entered puberty early or mom entered puberty late, then that can happen to this child as well. Okay? If they are obese, we already talked about, it could go earlier. And the same, kind of the opposite end of that, if they are malnutrition, okay? If they have a lot of stress, if they exercise very heavily on a regular basis, that may actually delay the onset of puberty. This thought is that you have to have this critical body mass of 48 kilograms in general for patients to go into puberty. That's probably not completely true because we know there are adults that are not even 48 kilograms, right? And they have gone through puberty and they have multiple kids. But the thought behind this is just saying, like, the body understands that the whole intent of going through puberty is for reproduction. That's just how we were designed, right? And because the body understands that, if the body is not in this homeostatic kind of path, it's not going to push this patient or this child into puberty. Again, psychological issues, stress, that can delay puberty typically. And even where somebody lives, okay? You live in, I don't know, Nebraska. Right? Let's choose Nebraska, Midwestern area, right? And, you know, there's a lot of farms there. People tend to eat a little bit differently in Nebraska than they do, say, New York City, right? And so because of where they live and probably the diet in which they are eating from, that's going to change how these people go through puberty as well, either early or later onset. When we think about puberty, we think about it though as more of a things occurring over this 3-year time frame, but in a specific order. Okay? Thelarchy, pubarchy, and we have a growth spurt, we have menarche. So we ideally think that the first thing we're going to see is this breast bud development. We're going to see some pubic hair that develops, then growth spurt. We're going to have that growth spurt 13 to 14 years old, okay? And then ultimately we're going to have that menarche. All throughout that, we have what's called adrenarche, which is release slowly of these sex steroids. Certainly, there are patients that don't follow the book, right? There are certainly patients that come in and they have pubic hair development before they have breast bud development. That is considered abnormal, but it can be a part of a normal sequence. So in other words, we would say, yeah, that's a little abnormal, but it doesn't mean that all these patients need workup. And they don't need some big workup to figure out, why did you get pubic hair before you got breast bud? Sometimes it just happens. Okay, it's nothing really to worry about. What you want to do is you want to follow these patients if you're in a situation that you're going to be seeing adolescent patients. Follow them. Hey, come back in a couple months from now. Let me take a look, and we'll make sure that we are developing breast buds. Because if we only have pubarchy and puberty doesn't progress, that's the time they're going to start working these patients up. We don't have to work them up just because they develop pubic hair first. So in order for you to remember this sequence, okay, some really smart people that probably got paid a lot of money developed this mnemonic, tupupme. So we think thelarchy, we think adrenarche. Adrenarche goes all throughout puberty. And we think pubarchy. And then the other P is peak growth velocity, which is getting taller. And then last is menarche. So your T for thelarchy, your adrenarche, PU is your pubarchy, onset of pubic hair and axillary hair, your peak growth velocity, and then your menarche. The first sign, again, that we typically will see is going to be that thelarchy or that breast development. That usually occurs Tanner stage 2 around 10 years old. Again, these are numbers that you don't hang your hat on. If someone comes at 9 and they have breast bud development, that can certainly happen. Okay, it doesn't mean that they're developing too soon. We'll talk about developing too soon, and 9 is not it. Okay, we have adrenarche that's going to occur all throughout puberty. That's a release of those sex steroids. Pubarche around 11 and a half or so. And then we have that growth spurt, 10 and a half to 13 and a half, and that goes from Tanner stage 2 into Tanner stage 3. Menarche typically is going to occur about 2.5 years after thelarche. Okay, do you guys see that's underlined? Do you hear that emphasis in my voice? So about 2.5 years after thelarche, that's going to be the onset of menarche. Of course, there are things that can change all of this. Okay? Race, BMI, and again, we already talked about puberty. Sometimes that can be our early sign. All of this is because of the HPO axis. Right? The HPO axis is either working appropriately or it's not. And if patients are going into puberty and they are progressing as normal, then we would say our HPO axis is probably working appropriately. You guys have learned about the HPO axis. We'll talk about the HPO axis a couple of times today. And we think about the HPO axis coming from initially from our hypothalamus, going down to our pituitary. Pituitary is going down to the ovaries, right? So we have GnRH that's released from the hypothalamus. That is going to stimulate the release of FSH and LH at the pituitary. And that's going to go down and stimulate the release of estrogen and progesterone. Through negative feedback, once we get to a certain estrogen level, it's going to come back and shut off the production of that FSH and LH. It's going to go back and shut off the production of that GnRH as well. Okay, so we have positive and negative feedback loops that must work in concert with each other. They must work in concert. If they don't, these patients will not progress through puberty as we would normally expect. So around the age of 8 is when the hypothalamus is going to really start releasing that GnRH. We're going to have an increase in production of GnRH. Okay? The issue is not the constant production. That's not what pushes patients into puberty. It's actually the pulsatile release of GnRH. So we have GnRH that's being released really throughout our younger years. But it's a constant level of GnRH. The body gets used to it. The body doesn't really care, like, okay, we just continue on as normal. But now when you get GnRH that's going up and down, up and down, up and down, that's what pushes these patients into starting puberty, the pulsatility of that GnRH. Okay? And then that, in turn, is going to cause release of that FSH and LH from the anterior pituitary. Okay? FSH and LH works on those, again, on the ovaries, okay? And that's going to cause that release of your estrogen for your progesterone. But what you also have is, we can see over to the side, we have that LH, we have that FSH here. Well, this picture is a picture, anybody know what this picture is of? One-dimensional representation of? A follicle, okay? Things like theca cell and granulosa cell. They can ring any bells? So long ago, right? But the theca cell, okay, so that's the outer layer of those follicles that are in the ovaries. LH works in concert with the theca cell to turn cholesterol into this testosterone, this inosine-dione testosterone. Okay, and then FSH is going to work in concert with the granulosa cell to turn that testosterone into estradiol or estrone, which is a strong estrogen level. Okay? And that's really important because if those things don't happen, the patient can go into puberty, but they won't ovulate appropriately after they go into puberty. And they may start puberty, but then puberty may get stopped. So we've got to have all of these things that are working appropriately together for puberty to continue on and for the patient to have reproductive capabilities. If someone comes in and they have evidence of female sexual characteristics before the age of 8, we technically consider that precocious puberty, meaning puberty is occurring earlier than we would expect. We talk about puberty signs and symptoms around the age of 10. We have talked about, yeah, maybe it'll occur early, but we're saying, like, the book answers, if it occurs less than 8 years old, we might need to be concerned. Okay? may not, but initially you need to be concerned. More often this happens in females than males. And again, where does this person live? What is their diet like? Are they overweight? Because we know there's a potential for those patients to go into puberty earlier. And when we think about precocious puberty, there's really two main causes. And we've got central causes and we got peripheral causes. The problem is, in 75% of these patients, we have no idea what the cause is. They get completely worked up by our pediatricians, and the pediatrician's like, I don't know, we're just going to continue to monitor. Okay? But when we think about those central causes or the peripheral causes, so central, think brain, think GnRH dependent. Okay, what if someone had some sort of CNS tumor, so brain tumor or brain anomaly? They had significant head trauma, hit the head, with by their kid brother who was playing baseball. Probably would be really funny to hit his sister in the head with a baseball. Never happened to anybody? No? Oh, so you know what's happened. Or they had some sort of ischemic vein. He's like, not me, it wasn't me. Maybe they had chemotherapy, maybe they had radiation. Something has affected the brain in these patients, and that is what's causing them to go into puberty a little bit earlier. These patients look like females. They're called isosexual. They look like females. Okay? So if we think about something in the periphery, as a peripheral cause, their DNA is independent. It has nothing to do with the brain. It's something on the outside. Maybe there's some sort of androgen secreting tumor or an estrogen secreting tumor that's causing this. Maybe this person has something where they have a whole bunch of ovarian follicular cysts that's causing this. So we want to think about things outside the brain, even something like congenital adrenal hyperplasia that affects the adrenal glands. How does that work? Well, if you have congenital adrenal hyperplasia, especially the non-classic form, you can't convert. There's a problem with the adrenal glands. You can't convert that testosterone into the estrogen. Okay, so there's the problem that you're running into. So you want to know that there's peripheral causes and there's central causes that are associated. But the majority of these patients, we can't really identify a main cause. Okay, we have GnRH dependent, those central causes. We're going to have early maturation of that HPO axis, okay, but puberty is going to occur in the same sequence. So we still would technically think that thelarchy is going to occur first, okay, and then the rest of it will follow. How we identify this is something called a GnRH stimulation test, and we can do other labs as well. We can do LH, we can do FSH. Typically, you're going to have high LH and FSH, and then that increases your estrogen. These guys are treated with GnRH agonists. Why does that make sense, or does it not make sense? The problem is a GnRH problem.
Sustained, it's not falsified.
That's exactly it. So again, the body doesn't care if we have a continuous exposure to GnRH. The body cares and responds if we have a pulsatile GnRH. So by putting them on GnRH, we're preventing that pulsatility. We're preventing those ups and downs. So the body just goes back to its normal pre-pubertal state to say, oh, I'm just back to my normal. I don't have to go into, I'm not going to have these changes that occur. We put these patients on this GnRH constant exposure until about what age would you think? Yeah, 10, 11, 12. Once their time to go through puberty is. We're going to take them off the medication and then allow them to go through puberty. But we're going to give them a continuous GnRH exposure, not that pulsatile. When we have peripheral, okay, again, GnRH independent, we do not have early maturation of the HPO axis. This is actually something is being excreted, some sort of sex steroids are being excreted in the periphery, and that is causing this increase in estrogen. We can still do our labs, LH, FSH, I would add a thyroid in there for sure, okay? And typically on this, our FSH and LH are going to be low. Okay? We have a negative feedback from that increased estrogen. We got to figure out the underlying cause. If we don't think this is a central problem, we've got to figure out the underlying cause, and then we treat that underlying cause. So if it's something like congenital adrenal hyperplasia, any idea how to treat that? Well, you put them on steroids. So hydrocortisone, prednisone, okay, and ovarian tumor or cyst, ultimately they may have to have removal of that. So we've got to identify the problem, and then we fix the problem, and that will halt the progression into precocious puberty. If we do not catch this, and we do not treat this appropriately, the biggest risk is these kids aren't going to grow, okay? And for those of you that have kids, kids are mean, right? They're mean. We have a young kid in our neighborhood, and that poor kid, he's probably 4'2", pretty like in the 9th grade. I mean, he's so short. And the kids just make fun of him so bad, and he's like, I can't help it, my parents are short, right? But kids are mean, so we want to help in a time period where these kids are already have a lot of other issues, school, and things. We want to take this off of their plate. So we want to give them the best likelihood of growing to a normal height. If you have this constant release of estrogen that occurs earlier than expected, it's going to cause premature closure of those growth plates. Okay, we're going to have fusion, so that these patients will not grow. How do you identify then whether or not how far these guys are in their pubertal sequence? How do you? That's not a good answer. How do you identify what age their bones are at? An X-ray, right? We call it bone X-ray. We check for bone age. What do we X-ray? Hand and wrist, right or left? Why? Huh? Because so this may be something I'm making up. I read it, so I'm not making it up, but somebody made it up. The thought is, the reason why they use the left hand is because most people are right-handed. Sorry, left-handed people. But most people are right-handed, and so they're more apt to have had trauma to that right hand, so they use the left hand. Now, maybe that's a wives' tale, I don't know. But universally, whether you're left-handed or not, they're going to use the left hand because that's the comparison that they have been taught to compare that bone age to. Okay? So they're going to identify the patient's bone age, and that can indicate that usually it's based by 3 years, and we can see on that bone age. We also want to treat this to help, again, reduce psychological stress associated with these changes. Okay, if you have a 6-year-old comes in and they have breast bud development, they have axillary hair, and they're really short, like someone's probably going to say something about that, right? So we want to minimize the psychological distress on these patients by catching it. And the majority of you, especially active duty folks, are probably going to be seeing adolescents. I know we saw them at Bragg all the time. So the majority of you will probably be seeing adolescents. You'll be doing sports physicals, and it's important for you to identify if any of these things are occurring. So not only precocious, but we'll talk about delayed as well. Ultimately, we want to maximize their height by reducing the amount of circulating estrogens. We want to synchronize their puberty with their peers. And then we want to decrease the amount of stress that they already have on them by just kind of making them work like typically discontinuation, like we talked about, around 11 years old. Sometimes they will only have premature development of a single system. So only the fact that they had breast bud development at 7 years old, but nothing else ever transpired after that. Okay, so at 7 years old, dad brings a patient in, like, oh, breast bud, like, isn't this weird, like that breast bud development? And nothing else on physical exam. You can watch those patients. Come back again, 3 months. Let's see if we have any progression in 3 months. Oh, you tell the parents, I want you to watch for development of pubic hair or axillary hair. I want you to watch for development of acne, because usually 6 and 7-year-olds don't have acne. That's that adrenal, that's release of those sex steroids. And put that on the parents as well to watch and have them bring the child back. But ultimately, bring these patients back and gives you 3 months or so to check on them. These patients that have only a single system that's developed, their bone age will be normal. So we're not gonna see that advancement of 3 years of their bones, it's gonna be a normal bone age. Again, we can have early onset of puberty, we can have delayed onset of puberty as well. So if there's been no thelarchy by the age of 13, or a delay of over 4 years between thelarchy and the completion of puberty, or no menses by the age of 16. Now, I have 16 in here, because that's what Dr. Klein says, that pediatricians use. Our reference book says 15, so I'm sure that you guys between midnight and 4 are probably combing the book, the pages of Williams OBGYN and Women's Health, I'm sure of it. But we're gonna go with 16 because that's kind of what the pediatricians go with, right? This is pediatrician stuff. Okay. So no menses by 16. There can be a lot of different causes of delay. So maybe it's constitutional, just a late bloomer, if you will. They're getting there, but they're just late to the training, right? They're late in getting there. Oftentimes there's a family history of mom or dad that was also late in the development of the secondary sexual characteristics. It could be something like chronic anovulation, okay, where they don't have, they have this estrogen that is developing, where they are not, what's the word I'm thinking of? Oh, my brain today. They're not going into ovulation because the estrogen levels kind of peak off. They don't go up as high as they want, as they need to push these patients into ovulation. Okay, so if they're not ovulating, then essentially HPO axis is not working in concert together. You can have androgen insensitivity syndrome. We could have anatomic problems. So in other words, there actually are having a menstrual cycle, but we just can't, or can have anatomic problems like obstruction. Okay, we can have hypo, just like we talked about already with Turner syndrome. We can have premature ovarian failure as a cause as well. So these patients with premature ovarian failure, they're going to have high FSH and LH, and we're going to have low levels of the estrogen and progesterone. So a lot of different causes that we want to think about. One of the main causes that we're going to see nowadays in kids is stress. Especially, I don't know about other parts of the world, but here in Texas, in order for kids to really be, to participate in school sports, most of them have to do some sort of club sport to really hone in their skills. And that creates a lot of stress for these kids. They're working out 5, 6, 7 times a week. If they're in cross country, they're probably running 4 or 5 miles a day just to prepare for cross country, track, basketball. So all of that stress on these patients' bodies can cause a delay. So you want to make sure you get a really good history of what are these kids doing in school, what are their grades like, what are they doing sports-wise, what does their diet consist of, all of that. We want to also get a family history. Okay, what is a family history? Again, when did mom or dad go through puberty? And what about, does this patient take any chronic medications? Things like asthma or allergies. They may be on chronic steroids. So chronic steroids can cause problems with these patients for development of puberty. Okay, physical exam. When we do this physical exam on these patients, we're going to look for evidence of puberty. We're going to look for breast bud development. We're going to look for that axillary hair. Look to see if they have acne or if they have excess acne. Okay, things again like PCOS can cause excess acne. If someone has PCOS, a lot of times that can cause delay in puberty. We're going to check that bone age, just like we talked about with precocious puberty. You're going to check the bone age here to see what these patients are at for their growth plates. And then labs, okay, FSH, LH, estradiol. We're going to check all of that. We're going to look to see, does there seem to be a problem at the gonads, okay, the ovaries themselves, or is it a problem up higher? Is it a problem with the pituitary, or even higher than that, generate the hypothalamus? For these patients, depending on what age they're at, Okay, if they're 16, we probably need to have some sort of intervention. Okay, depends on what age they're at, depends on what their family history is, what's their diet like, what is their activity like. But if you're going to treat them, usually it's going to be some sort of low dose estrogen to kind of push them into puberty. So that's it. So we've got puberty, okay? We've got precocious puberty. We've got delayed puberty. You got to know how the HPO axis works with that. You know that it's GnRH pulsatility that pushes these patients into puberty, not just that continuous GnRH exposure. Okay? Now we're going to go into the menstrual cycle. And the menstrual cycle has several different things that we'll talk about that are associated with these phases that we'll talk about. But in general, we think about the menstrual cycle as has this bleeding phase, it has a follicular phase, and then it has a luteal phase. The bleeding phase starts the first day of our menstrual cycle is considered the first day of bleeding. And we use that as the first day of our menstrual cycle because most women can tell you the day that their period started. Most women cannot tell you the day that it ended because it ends and then the next day they have a little spotting. And then the next day nothing and then a little bit of spotting, right? So it can kind of go on for several days, but they can almost always tell you when the first day started. Menstrual cycle itself can last anywhere from 21 to 35 days, but usually around 28 days. The bleeding phase is usually from 3 to 7 days or so long. And the average amount of blood loss during the menstrual cycle is about 20 to 60 mLs. So to quantify that for you, each menstrual pad or tampon will soak up about 5 to 10 mLs of blood. Okay, so each one. So these guys are going through a pad or a sanitary pad, or sanitary tampon, maybe 2 or 3 times a day for the 60 mLs. As a person gets older, we have decreasing amount of circulating estrogen, and that decreasing amount of circulating estrogen affects the endometrial lining. So their menstrual cycles are going to become less and less and less amount of bleeding and more irregular. The most irregularity that we see associated with the menstrual cycle is going to be at the very beginning of the menstrual cycle, those first couple of years, and towards the very end of the menstrual cycle, around 45 to 47 years old. So again, patients are often brought in by their parents because of menstrual irregularities, especially in that first 1 to 2 years. Those are all considered normal. Doesn't mean that, you know, in the right person you don't need to do an HCG on them. It doesn't mean in the right person you don't need to do some labs like thyroid. But in general, we expect those first couple of years to have irregularity. Well, the patient will have, you know, they have their menstrual cycle and they'll go 3 or 4 months and not have anything. And then they'll have their menstrual cycle in another couple of months without anything. And we go back to that HPO axis. Okay, the HPO axis, so it's a regulator of our female reproductive hormones, mainly estrogen, progesterone, LH, FSH, and then we have our GnRH as well. And we know that GnRH is released, it affects the release of our LH and FSH. LH and FSH then go down and they affect the release of estrogen and progesterone. Estrogen and progesterone are going to be released in kind of fluctuating levels, concentrations throughout these different phases of the menstrual cycle. Primarily estrogen in the first phase, and we have primarily progesterone in the second phase. Well, again, when we look at these positive and negative feedback loops, once we get to a certain amount of estrogen, it's going to come back and start shutting off the FSH and LH production. So we have 4 integrated subsections or integrated subcycles that are associated with the menstrual cycle. We know that it's about 28 days, but can go up to 35 or be down only to 21 days depending on the patient. We've got that hypothalamus that's part of this. We got the anterior pituitary that's part of this, and then we've got the ovaries. We also have the endometrial lining, okay, that is really responsive to estrogen. So if anywhere in this HPO axis or even at the endometrial lining, something is not working, then these patients will come into you after those first couple of years with either new onset of menstrual irregularities or continued menstrual irregularities. It's all from the HPO axis. We also know, not only is the HBO axis involved, but we also know that before we're born, okay, we have all the oogonia, or all the eggs we're ever gonna have. We have 1 to 2 million before birth. About 400,000 eggs are left at puberty, okay? But again, we can't have 400,000 kids, right? Every time the body produces one primordial follicle, one main follicle, they produce 15 or 20 others that degenerate, that go away. I only give one, typically, unless you have twins or more than that, but that one is a primary. About 400 ovulations in a female's lifetime, about 400. And I like to put these numbers out there, not really for testing purposes, but I just think it's really interesting when you look at, holy crap, I have 2 million eggs, and I still have 400,000 eggs, and I got 400 ovulations. That's a lot. It's a lot of stuff, right? All right, follicular phase. Follicular phase. Follicular phase is going to begin at the first day of our menstrual cycle, and it's going to end when ovulation occurs. Lasts about 14 days. Okay? It's not really specific to 14 days. Every 14 days depends on how long the patient's menstrual cycle is in total, and it depends on estrogen levels. Okay? Again, it can be variable because we need estrogen to be at a certain level for ovulation to occur. Right? Estrogen is going to be your primary hormone during the follicular phase, and we kind of separate the follicular phase into an early part and a latter part. The early part is going to be consistent of your menstrual cycle or your menstrual phase. Okay? That's usually day 1 through 5 or so. Okay? That is the shedding of the endometrial lining, and during this phase, our estrogen and progesterone levels are going to be lower. As we go into that later follicular phase, around days 6 to 14, now we're going to start to have regrowth of that endometrial lining. We're going to start to have proliferation. So this is also called the proliferation. Proliferation meaning it's going to start to thicken up, regrowth of the endometrial lining, and that is due to increasing levels of estrogen. Once we get towards the end of that follicular phase, and we're going to try to get into ovulation, okay, we have that increased FSH from the pituitary. And remember, FSH stands for follicle stimulating hormone. So it's going to go down to the ovary, and it's going to stimulate that dominant follicle to start kicking out more and more estrogen. Okay? Once we get to a certain level of estrogen, that ultimately is what is going to cause this patient to go into ovulation. If we don't get to that certain level of estrogen, so in other words, if that FSH is not stimulating the follicle enough, okay, by acting on the theca cells, by acting on the granulosa cells, then these patients won't go into ovulation, and they actually won't even go into the next phase. So they've got to work in concert with the theca and the granulosa cells to increase the amount of estrogen that is pushed out. Okay? So around day 14, we've got that follicle, okay? It's working appropriately. We've got the theca cells and the granulosa cells working with FSH and LH. We've got this kicking out of the estrogen. And then once that estrogen level gets to about 200 picograms, okay, 200 picograms, then it sends back to the pituitary for the pituitary to do an LH surge. Okay? That LH surge will not happen if estrogen stays below that 200 picograms. Okay? So if for some reason it doesn't get up to that level, then LH surge will not happen. But when it does, so it usually takes about 50 hours or so for that estrogen level to increase. Okay? And then we have that LH surge that occurs, usually within a couple of days. Okay? And then LH surge, once that occurs, then we have ovulation that takes place. So again, you've got to have estrogen. If you don't have that increase in estrogen, this is not going to happen. As long as we have the increase in estrogen as normal, and we get up that 200 picograms, it takes about 50 hours for that to happen, then we're going to have that LH surge. You'll call that positive feedback loop back to the pituitary. We're going to have an LH surge, a sudden kick out of LH. That LH surge lasts about 12 to 36 hours, after which we're gonna have ovulation, okay? And some books will say 8 to 20 hours. I think in general, we think about a day, day and a half for that LH surge. Once we have the LH surge, we have ovulation, and then that oocyte hopefully gets into the fallopian tubes and gets implanted, or it degenerates and goes away. Depends if it's fertilized. We have about 24 hours for that ovum or that oocyte to be fertilized. After 24 hours, if it's not fertilized, it goes away and the patient will not become pregnant. So again, start at the beginning. We've got our follicular phase. Follicular is going to start at the menstrual cycle, day 1 of the menstrual cycle, and it's going to end with ovulation. Okay? Estrogen is going to be our primary hormone during that follicular phase. Okay? We've got our early follicular phase, which really is our bleeding phase. And then we've got our later follicular phase, and this is where we're going to have regrowth of the endometrial lining, right? That has just shut off. Once we start to have regrowth of the endometrial lining by estrogen, right, we're going to have an increase in estrogen level that's coming from that dominant follicle. We'll get to that LH surge. Once that LH surge occurs, we get ovulation within a day, day and a half afterwards. The ovum must be fertilized within 24 hours of ovulation, otherwise it's going to degenerate and go away. So that leads us to our ovulation. After we have our ovulation, then we go into the next phase. We go into our luteal phase. This is also called our secretory phase. And that's typically around days 15 to 28, depending on the patient. Usually it's going to begin that day after our LH surge. So we have our ovulation, which is 1 to 2 days after, and then after that is when our luteal phase is going to start. And again, about 12 to 14 days. This tends to be more of a defined phase, because it really is based on the life of the corpus luteum, which is why it's called the luteal phase. Corpus luteum dies after about 9 to 10 days if there's no fertilization. So it's going to be more of your defined phase. Your primary hormone during this phase, progesterone. And what progesterone does is progesterone promotes gestation. So it's going to have these secretory functions. It's going to start to secrete things like glycoproteins because it wants to make this really nice home, this really nice nest for the egg to be fertilized and for the egg to live in. So it's going to promote gestation during this luteal phase. If we have fertilization that does occur, so progesterone got in there, it made this nice secretory, this nice area in the endometrium for the egg to kind of live in. If fertilization occurs, we have the development of a trophoblast. Okay, the trophoblast, or the embryo, if you will, produces HCG. And the point of that is to maintain the corpus luteum. Because when does the placenta come in? Immediately? No. Okay, usually 8 to 10 weeks before the placenta is actually functional. So who does that? Who does the work of the placenta then? The corpus luteum. Okay, the corpus luteum does the work of the placenta. So the trophoblast is sticking out this HCG to maintain the corpus luteum, to maintain the pregnancy. Right? That's why very early on our HCG levels are super high. They go up really quickly. Okay? And then once the placenta takes hold, they kind of come down and they plateau. All right, let's take a break. Graphic representation of what's happening in these different phases. Okay, at the top, you've got a cycle without conception, another cycle with conception. You can see at the end of that cycle with conception, we've got an increase in the HCG level. We've got a corpus luteum that is thriving, and it's kicking out, it's being held together by the HCG that's being produced from the trophoblast. If we have without conception, we still have the same things going on, right? We still have increase in our estrogen, increase in our estrogen here. That increase in estrogen in that follicular phase is going to lead to that LH surge. Okay, once we have that LH surge, we have ovulation that occurs. Okay, and we go into our luteal phase. Luteal phase primarily is progesterone. It's going to promote gestation by making the endometrial lining super comfy for that egg to kind of sit in and grow and grow and grow and grow. If we don't have fertilization, it won't grow, it's gonna go away because the corpus luteum is gonna go. If we don't have a corpus luteum, okay, if we don't have a trophoblast to keep the corpus luteum around, okay, then we're not gonna have progesterone. So all of those go hand in hand. So trophoblast kicks out HCG to keep the corpus luteum around. If we don't have a trophoblast, we don't have a corpus luteum, progesterone levels are going to decrease, and we're going to go back to the beginning of our fertility. If you have, at the end, before you take our exam, if you guys don't understand that, please come and speak to me about it so you need to have a pretty good understanding of what's happening in this menstrual cycle. The phases, what hormones are important in those phases. You've got to know also about the increase in estrogen in the luteal phase. If, for some reason, we don't have that increase in the estrogen, okay, so we really don't even have the maturation of a follicle, because it's that follicle that kicks out the estrogen. But for some reason, we didn't produce this mature follicle. We don't have that estrogen that's being kicked out. We're not going into ovulation because you don't have any late surge. If you don't have estrogen at that 200 picograms, late surge is not going to happen. You're not going to go into luteal phase, which means you're stuck in the follicular phase. So you're stuck in the follicular phase. These patients who are going to come in, maybe they're coming in because they've been trying to get pregnant and they can't get pregnant. Okay, so that maybe their fertilization can't occur because they're not ovulating. Right? But what they do is they remain in this follicular phase, and so they're going to have this persistent release of estrogen, but not enough to get to 200 picograms. It's just this constant low-level release of estrogen. If you have this low-level release of estrogen, and we think about the follicular phase and what estrogen does to the endometrial lining, which is what? Thickens it. It thickens the endometrial lining, okay? And we have this constant low level of estrogen. Ultimately, what's going to happen is the body is not going to be able to tolerate how thick the endometrial lining gets. The endometrial lining will get so thick that it outgrows the blood supply. So then it's going to slough off at irregular times, and that's going to be the bleeding. So these patients will still say, oh yeah, I have a menstrual cycle, because they just know if they're bleeding, right? They have a menstrual. Well, when was your last one? Oh, it was like 6 weeks ago. What about before that? Oh, I don't know. They're like irregular. So they'll come in and saying their cycles are irregular, but they just believe that they're cycles. And they're irregular because when that sloughing off occurs from the excess of the estrogen is not going to occur at the same time every single month. So think of it as like a plant, and you put a plant in the container, and you water it, and you feed it, and you fertilize it. Well, ultimately, that plant outgrows, and what happens? For you that know about plants, it dies, because there's not enough room in that pot for it. Well, the same thing is happening in the endometrial lining. We got estrogen, that's our fertilizer. It's fertilizer. Not enough to make a difference, but enough to thicken that endometrium. And ultimately, the blood supply say, I can't do it anymore. I can only do about half of this endometrium. The rest of you have to go away. So it does. It sloughs off in bleeding. Okay, it's going to slough off, and that's going to be your bleeding. But it's going to occur at irregular times. So our normal menstrual cycle is a progesterone withdrawal bleeding. We have a decrease in progesterone because we no longer have that corpus luteum. This, from anovulatory cycles, is an estrogen withdrawal bleed. An estrogen withdrawal bleed. Okay, because that estrogen is thickening the lining of the endometrium. Most of the time, these patients are going to come in with those irregular menstrual cycle, or ultimately, the endometrium gives up altogether. And it says, you can stay thick if you want, I can't, there's nothing else I can do, and it doesn't bleed at all. Usually after irregular cycle, 3, 6, 9 months, they're going to come in and they haven't had a menstrual period in several months now. because there's nothing, there's a bunch to slough off, but the body just can't do it, so it's not bleeding, it's not sloughing off. Again, often with these guys are gonna have infertility because they're not going to the luteal phase. If you don't go into the luteal phase, okay, if you don't have ovulation, I mean, you can't go into the luteal phase. They're not having ovulation because they're not having that estrogen increase enough, so they're not having the LH surge. So they are stuck like 51st date, right? That was a good word back in the day. 50, they're stuck in the follicular phase. You keep going around and around and around in this follicular phase. It is not uncommon to have this at extreme age. When they first start their menstrual cycle, they're going to have irregular menstrual cycles because of that ovulation, because they're not ovulating every single time. Immature HPO axis. And then later on, as they approach menopause, things have just given out. Things are worn out, right? So the HPO axis is doing that, but it's worn out. So it's going to start having these anovulatory cycles as well. We got to think about HPO axis problems. If someone comes in and they're in their normal reproductive time period, so we're going to say, 17 to 45 or so, and they're coming in with these irregular menstrual cycles, okay, make sure they're not pregnant, would be one, because people that are pregnant can still have bleeding. Okay? Oftentimes, it's not unusual for them to feel like they have regular menstrual cycles in that first trimester. Okay, and then let's figure out if there's what's going on with the HPO axis, as long as the HCG is negative. So thyroid, LH, FSH, estradiol levels. Okay. Something like celiac disease can also cause issues with HPO because people aren't absorbing appropriate nutrients, and that's going to start to affect that HPO axis. So anovulatory cycles is really considered a diagnosis of exclusion, meaning you've got to figure out what the heck. Why are you not ovulating? What is the cause for you to not ovulating? It's not really a diagnosis per se, it's secondary to some other issue. In other words, you can have eczema. Okay? Just because you have eczema doesn't mean you have an internal problem. When you have anovulatory cycles, there is something specifically that is causing that to occur. Okay? We can have amenorrhea. Okay? Amenorrhea, absence of menstrual cycles. Or absent menstrual bleeding, or not bleeding. Okay? This can occur intermittently, okay? Or these patients may present to you within several months of amenorrhea. I have not had a menstrual period in several months. We've got primary, which means they never had a menstrual cycle. We have secondary, so no menses by the age of 16 in the presence of normal secondary sexual characteristics. So otherwise they've got respite development, got pubic hair, axillary hair, but they're just not having a menstrual cycle. Okay, no evidence of no menstrual cycle, and they have no secondary sexual characteristic, and they're 14 years old, okay, or no menses within 3 years of theolarchy. Those are your definitions. Again, I would know, make sure you understand those. Okay, secondary. I had menstrual cycles. They were normal, or maybe they weren't, maybe they were regular, but now I have none. Now I've had none. 3 months I've had none. Not 1 month, not 2 months. The definition for secondary amenorrhea is 3 months of no menstrual cycle, no menstrual bleeding. Now we want to think about all causes of secondary amenorrhea can also cause primary amenorrhea, right? PCOS, that can cause secondary. It can also cause primary. Hypothyroid can cause both. But all causes of primary cannot necessarily cause secondary, right? In other words, let's think about Mullerian dysgenesis. Can it cause secondary amenorrhea? You don't have the structures. You never have the structures. You can't bleed. So just because primary cannot cause secondary, but secondary that can be primary causes as well. There's a lot of different causes of primary amenorrhea, but we still go back to kind of the HPO axis. And we still think about hypo, and maybe ovarian insufficiency where the ovaries are not working appropriately. And we think about something called eugonadism, meaning the labs look okay today, in this moment in time. That's part of the problem with labs, right? We're getting labs today. And I don't know what those labs are gonna look like in a week from now, depending on where this patient may or may not be in their cycle, right? But things like congenital adrenal hyperplasia, PCOS, all of those can cause primary amenorrhea. And then we've got, hypo, no breast bud development, because if you have hypo, if you don't remember that breasts are very estrogen dependent. And if you don't have enough circulating estrogen, you are not going to have decent breast development. You potentially could have a little bit of breast bud development, but then it kind of stops and we don't have anything else. So breasts are very estrogen dependent, and if the ovaries aren't working correctly, they're not releasing estrogen, and so these patients typically either have very, very, very small breasts, okay? And we're not talking about necessarily appearance of the breast or size per se. We're talking about appearance, meaning when you look at the tender stages of breast development, okay, we have breast buds, and where they're just simply lifting off the chest wall, and then you have an areola, which is coming out a little bit more in your 2 to 3, right? So that's what you're seeing on physical exam, not necessarily their A cup or B cup or C cup. On physical exam, you're like, look, I have just a little bit of breast bud, it's not even lifting off the areola, but they say it's been like that for quite a while, like there's never been any progression of the breast. Right? So CNS disease, pituitary adenomas can cause this as well. So this is something like we think about getting a prolactin on. Again, eating disorders, stress. I cannot tell you enough to think about that in these patients, especially nowadays. These young patients get really stressed about a lot of things. Social media is probably really good for the majority of people, but it's really bad for a lot of people as well. Secondary amenorrhea, we think about causes for that. Most common is going to be pregnancy. 32-year-old female comes in, she hasn't had a menstrual cycle in 3 months. Previously she was normal, HCG. Pregnant until you prove that she's not with an HCG. Second most common, anovulatory cycle. Something is causing her not to have ovulation. Okay? Something is causing that estrogen level not to increase. We've got something with that primordial follicle. So all of those things are causing this patient to be stuck in that follicular phase. If someone loses a significant amount of weight, okay, or they have a very low BMI, that can cause it. The BMI is less than 10% of ideal BMI. That can cause these patients to go into amenorrhea. Exercise, nutrition deficiency, leptin deficiency. We talked about adipocytes already, so they're very, very thin. Okay? And they can say, look, my mom is very thin, my dad is very thin. Why is it affecting me? Sometimes that is the case, and they're very, very thin. And then diet, like PCOS, we've got things that can suppress our GnRH, right? So like elevated prolactin levels, if they have a tumor, that'll suppress GnRH, and ultimately you're gonna have that low to normal FSH/LH. We've got structural abnormalities that can cause amenorrhea. Some of this we talked about, like imperfect hymen. You can have cervical stenosis, meaning again, you are in fact, the patient is in fact probably having menstrual bleeding, it's just not coming out, it's an outflow problem. Okay, so cervical stenosis, this would be someone, think about women that have abnormal cervical cytology, or abnormal pap smears, and they have to get colposcopies, or they have to get LEEP procedures. Okay, that's going to causing some problems with the cervix, where that cervix scars down every single procedure, and then ultimately the outflow of that cervix gets obscured completely from scar tissue. Okay? We talked about vaginal septum already. Right? You can have uterine septum as well, and then labial adhesions. Labial adhesions. Typically, we don't see that as much in adults unless they've had some sort of radiation or something to their perineal area, when you might see a lot of lab component, But really want to focus on those primary labs. HCG, the FSH, estradiol, prolactin level, thyroid level as well. Because that's going to guide us on if we need secondary labs. In addition to our physical exam, is this a female that is looking more male, has more male appearing, so more virilized? Okay? If so, you may have something like PCOS. You may have a DHES you want to check, maybe a testosterone. So take your physical exam. Maybe they have significant acne, okay? Excessive hair growth. All of those things, if you see those on physical exam, then you can do your primary labs, but then you would bring in your additional labs as well. Radiologic studies can also be done. Okay, so depending, usually what I'll do is I'll do a set of labs on this patient, and depending on what their physical exam, what their history are, maybe I'll do a transvaginal ultrasound or a transabdominal ultrasound to take a look to see what structures they have. Certainly, if they've already had, if this is secondary amenorrhea, then it's going to change some of the radiologic studies that I would do if this is primary amenorrhea. If I have someone with primary amenorrhea, then I'd be more apt to do that transabdominal ultrasound or transvaginal ultrasound to make sure that they have the structures there to even have a menstrual cycle. Talk about MR, okay? MR really for female pelvic organs, that's definitely not the first line, it's not the second line, it's way down there in lines, right? We don't do pelvic MRIs very often. If we think someone has something like pelvic congestion syndrome, it's really good because it helps us look at the vasculature in the pelvis. Or if we can't identify maybe between adenomyosis and leiomyoma, then they will do it. But ultimately, don't think of that as a primary radiologic evaluation tool for females. It's not there. And then we've got a couple other there that you don't have to worry about. HSD we'll talk about later, and SIS we'll talk about later. So what do we do? How do we evaluate these patients? And it is different from primary amenorrhea to secondary amenorrhea. Okay? We do have differences. So you got to do your history and physical exam, primary amenorrhea. These are the younger folks that are coming in. Okay? Do they have any evidence of secondary sexual characteristics? If they do, we still have to do a pregnancy test. All right? If it's negative, then consider an ultrasound. Consider an ultrasound in these folks, right? Because if they have secondary sexual characteristics, so we see their breast bud develop, we see isolate hair, then they have circulating estrogen, and so we've got to figure out why they're not bleeding. And what they don't, now we're looking at FSH. Why are we looking at FSH primarily? We're looking at some other things too, but why FSH? Because FSH affects estrogen, right? FSH affects estrogen. If I don't have enough FSH that's going down affecting my estrogen, I'm not going to have secondary sexual characteristics because your estrogen, a lot of them are estrogen dependent. Okay? We've got to have circulating estrogen. So if we have a low FSH, okay, then we got to look. We got prolactin level, thyroid level. We got to figure out why is this low, and if it's less than 20, then or even less than 5, then we're looking for other, hypo, something in the HPO axis is affecting this. Okay, if we have FSH greater than 20, okay, greater than 20. So normal is typically less than 20. If we have greater than 20, that tells us what's happening, what's not working. It's bombarding the ovaries. Okay, it's bombarding the ovaries. Probably something going on the ovaries. FSH is like, hey, wake up, I'm trying to get you to work, right? And you're not, so I guess I'll just keep, it's like that brother and sister relationship, right? I guess I'll just keep pounding on you, keep getting you, right? So it's going to go down there, and it's going to hit the ovaries. You guys don't have any brothers or sisters? You didn't fight with them? No? Oh, you guys are so sensitive. So they're going to go down there, and it's going to keep hitting the ovaries because it's trying to get the ovaries to do their job, right? So if we have a high FSH here in the middle, we look at the ovaries and see if we're having any problems. Maybe it's an ultrasound. Okay, maybe we're going to look for karyotyping depending on what that ultrasound shows as well. Okay. So I wouldn't truly focus on this entire picked our brain here. I wouldn't focus on every little bit. You know, identify like, what do I do at the beginning? Because if you guys are gonna see these patients at the beginning, it is not likely that the majority of you will be working these patients up from the beginning to the end, okay? If you have somebody that does not have secondary sexual characteristics, okay, they have primary amenorrhea, they're coming to see you, once I don't see secondary sexual characteristics, I might throw some labs in them, and I'm putting a referral into pediatrics, okay, because they're the experts in evaluating these patients, okay? If they do, I'm gonna do a I am not gonna refer this patient without a pregnancy test, that's for darn sure, right? I'm gonna do a pregnancy test if they have evidence of secondary sexual characteristics, okay? If that's negative, okay, I'll talk to the patient and the parents and see if we do this ultrasound, otherwise I'm gonna refer them to pediatrics. You can do the basic evaluation and then there's nothing wrong with referring. That's why we have people that specialize. Someone comes in with secondary amenorrhea. So I had a menstrual cycle, but now I've not had one for 3 months. Now we're gonna do that pregnancy test. Also think about, that's negative thyroid. Think about prolactin levels. If prolactin levels are greater than 100, then we're going to consider a brain MRI for evaluation. Why would they have a super high prolactin level? Something going on in the brain, so that's affecting the atrial axis. Okay, we can do what's called a progesterone challenge test for these patients. Progesterone challenge test. What part of the menstrual cycle are we replicating by giving someone progesterone? Luteal phase. Okay, so we're starting with by giving them progesterone and replicating the luteal phase. Usually that's done with something like progesterone, 10 milligrams a day for 7 to 10 days. And we would expect that they would have a withdrawal bleed. Okay? If they have a withdrawal bleed, that tells us that they're not entering the luteal phase, right? In ovulatory cycle. We just replicated the second half of the menstrual cycle. We gave them a menstrual cycle, and they had bleeding, meaning they could have progesterone withdrawal bleed. That's normal, that's what we expect. So something is making them so they're not even going into the luteal phase. Does that make sense? Okay, so something like, you know, again, PCOS would be our most common thing, but the hypothyroid, hyperthyroid, those can cause it as well. If we do not have a withdrawal bleed, if we do not have a withdrawal bleed, now we've got to start back a little bit further. We're going to give them estrogen and progesterone, which simulates what? The entire menstrual cycle. Okay, now we're giving them estrogen. We're going to force that estrogen level up. So now they're going to the LH surge, they're ovulating, they should go into the luteal phase, and then we're going to give progesterone. Once they come off that progesterone, we would expect to bleed. Okay? If they're not bleeding, something's not right. Some structures are not there. Something is not working. There's outflow. Something is not right. And this is secondary amenorrhea, so we know that they have a uterus because they've had menstrual cycles before. So maybe some sort of outflow issue, maybe some scar tissue that has developed. Okay, if they do have a withdrawal bleed, now we got to bring FSH in there again. FSH greater than 40, that is concerning. Greater than 40 is concerning that their ovaries are not functioning well. Okay, less than 5, we think about stress. We think about celiac disease, eating disorders, the female athlete triad. All of that will cause really low FSH. All right, we got dysmenorrhea. Dysmenorrhea, painful menses, painful menses. So about a day or two before they have their menstrual cycle, the bleeding phase of their menstrual cycle, they're going to start having some abdominal cramps. Okay, oftentimes they might have some nausea associated with that, sometimes some vomiting, diarrhea, headache. And just like we saw with amenorrhea, we also have primary and secondary dysmenorrhea. So we got that cyclic pain for primary dysmenorrhea, it's going to occur. But these patients with primary dysmenorrhea, ever since they started having their menstrual cycle, it's been very, very painful for them. Ever since the beginning of their menstrual cycle. Okay, so what happens is they have that endometrial sloughing, and they get this release of prostaglandin. Now, some people are just really sensitive to the release of those prostaglandins, which is causing this dysmenorrhea. okay? But the thought is that most patients, most young girls, they have a menstrual cycle, and they don't have a tremendous amount of pain. So when they have pain with it, and maybe that they have this sensitivity or they're producing more prostaglandins, it also may be that they have a family history of having pretty significant pain with their menstrual cycles. So the idea is to reduce the amount of prostaglandins that these patients are developing. We have secondary dysmenorrhea. So in other words, I had a period of time where I really didn't have a lot of pain with my menstrual cycles, but now I'm having a lot of pain. A lot more problems and a lot more etiologies for secondary dysmenorrhea. Things like adenomyosis, where you have glandular tissue that occurs in the myometrium, which is the muscle of the uterus. We can have ovarian cysts. Pelvic inflammatory disease or pelvic infections can cause dysmenorrhea. Endometriosis is one of the major causes of dysmenorrhea. The problem with endometriosis, and we have a specific class on that, is it takes a long time for most of us to figure out that it is endometriosis because the signs and symptoms kind of vary. Again, here we're not really sure about the prostaglandin role. Yes, we know that we still have prostaglandins that are developing, okay, but most of the time with this, it's not specifically a prostaglandin problem, it's a secondary issue. And it's something else that's causing inflammation of the endometrial lining, which is ultimately causing that dysmenorrhea. Sometimes these patients will start off with having pain only during the menstrual cycle or a couple days before, but then over time they can say, yeah, it only used to happen, 3 or 4 days out of the month, but now I seem like I have it almost every day of the month. Something like endometriosis can cause that persistent discomfort, even outside of the menstrual cycle. Oftentimes, they will have other associated symptoms depending on how long it's been going on. They may complain of pain with intercourse, or pain with urination, pain with defecation as well, depending on what the cause is. So we diagnose this, right, is if someone's coming in, they're having menstrual cramps, they have no other signs or symptoms, okay, maybe we don't really need any additional studies or evaluation, especially if we're talking about primary dysmenorrhea. Maybe we can just treat them. Maybe we give them anti-inflammatories like an NSAID to reduce the amount of prostaglandins that are released, and then ultimately that should control their symptoms. But if they have increased risk for things like gonorrhea, chlamydia, pelvic inflammatory disease, if they're complaining of pain with urination, pain with defecation, and intercourse, those patients probably need more of a workup. And maybe they need a transvaginal ultrasound. Maybe they need STI studies or urinalysis. So you've got to look to see what their primary complaint is and what additional complaints they have associated with that to see if they actually need more of a workup or not. If you complete a pelvic exam and you don't really see anything on the pelvic exam, there's not a significant amount of discharge, they don't have cervical motion tenderness, you don't feel anything on your bimanual exam, then ultrasound, either transabdominal or transvaginal ultrasound, is typically the next evaluating tool of choice for these patients. But for primary dysmenorrhea, the main treatment is going to be an anti-inflammatory. It reduces the amounts of prostaglandins that we have. We can also put these patients on combined oral contraceptives, and what that does is kind of equal out the hormones. We don't have this fluctuation in hormones because sometimes this is a relation, the reaction to these hormones as well. And you can do a combination of that. There's nothing wrong with putting on anti-inflammatories and when they need it, so for 3 or 4 days out of the month, and then consistently having them on combined oral contraceptives. Levonorgestrel IUD can also work. The progesterone acetate, which is the Depo-Provera shot, that can work to reduce the prostaglandins and reduce the inflammation. And for secondary dysmenorrhea, we've got to try to identify what the underlying cause is. Why are you now having painful menstrual cycles when you didn't previously have painful menstrual cycles? So usually it's going to entail a physical exam, and then a lot of times ultrasound is going to be pulled into to help you with your differentials. Because we're talking about the menstrual cycle, I just throw this in here, I put it anywhere, but this is where I put it. So toxic shock syndrome, results from Staph aureus exotoxin. This was originally described kind of in the late 70s, but really came to highlight in the early 80s when we had multiple women that were showing up in different places, different ERs that were super sick, and associated with tampon use. Back in the 70s and early 80s, the tampons were designed to truly be super absorbent. Okay? So they were designed really to last the entire day. So they would hold upwards of 20 or 30 or 40 mLs of blood. And that's how this was identified, as these women were coming in and they were on their menstrual cycle, every single one of them, and they were super, super sick, hypotense, tachycardic, altered mental status with a rash and fever, and it was identified to be associated with that. Nowadays, they changed the, mid-80s, they changed the consistency of those tampons, and so we see this a lot. About 50% of toxic shock that we're going to see is still from tampon use. The other 50% are things like from surgery, like sinus surgery. Somebody that has mastoiditis or sinus infection, they can all have toxic shock syndrome. Classically, these patients will present with fever, malaise, diarrhea. They're going to have a rash, and this rash is not painful, but it looks like it's very, very painful. It's usually all over the body, not necessarily on the face, but definitely on the extremities. We'll see it a lot of times, a little bit on the abdomen. Hypotense. Okay, so when they come in, they are sick appearing. They may or may not have skin desquamation. Usually that skin desquamation, where the skin is peeling off, is kind of a later stage, maybe a week or two after the onset. So when I see patients with a rash, even if they are completely low appearing, this is always on my differential. So I talk about TENS. Have you guys had derm yet? Okay. I talk about toxic shock. I talk about toxic endocrinolysis, TENS, that's for TENS. Staphylococcus scalded skin syndrome. So that way you're thinking about really bad causes, but you're ruling out. Why would I say? I don't think it's toxic shock because they're not hypotense, they're not tachycardic, not febrile, they haven't recently had any surgeries, they have nothing packed anywhere. So like if they had a nosebleed, maybe they had a nasal packing in for a couple of days, those would be your reasons that they're not, it's not toxic shock. Okay? So the real treatment for this is antibiotics early on in support. IV fluids. These guys have to be hospitalized in the ICU. And despite appropriate treatment, early intervention, got antibiotics on board quickly, they get fluids, about 5% death rate still. And usually from acute respiratory distress syndrome, these guys will go to DIC, which is cardiopathy, and then ultimately it leads to myocardial failure for this patient. Okay, so these are our criteria: fever, rash, again that desquamation 1 to 2 weeks later, hypotension, and they have multi-system involvement. Maybe not necessarily when you see them, depending on what stage you're seeing them in, but ultimately they typically go into renal failure, liver failure. And so it's a very long process for these patients to recover from this toxic shock. We got to make sure that we send cultures on these patients, but we're not going to wait for those cultures to come back to treat these patients, right? We're going to get them antibiotics early on. And the antibiotics, triple antibiotic coverage, vanc, clindamycin, plus we have piperacillin tazobactam, which is dosing. You guys know you don't need to know dosages, but you need to know that this is your triple antibiotic regimen. These guys are not going out the door. If they come in menstrual cycle, hypotense, tachycardic, there's something to be concerned about. All right, we're going to finish with our menstrual associated psychologic disorders. First we'll talk about is PMS, premenstrual syndrome. Affects up about 20% or so of women, and it oftentimes doesn't significantly impact their life, but certainly makes them not feel well. Right? Fatigue, bloating, kind of a labile mood where they're happy 1 second, they're mad the next second. But they can have upwards of 300 different physical signs and symptoms that kind of PMS. It is associated again with mild to moderate functional kind of impairment. What I have seen a lot of times is patients will come to the emergency department, they'll have dysmenorrhea, okay, menstrual cramps, they'll have this late on mood, they'll have this headache, nausea, vomiting, bloating, and they're just seeking treatment. They're seeking treatment, and what else are they seeking? Quarters. And I'll be honest, when I was active duty, I was like, no, I'm not gonna do that. No. But I've become a lot softer in my retirement years. And when I see these in the emergency department, I do treat them. I give them usually a shot of Toradol. I watch them for 30, 40 minutes, allows that Toradol to Toralax to kick in. And depending on what they're doing, if they're going to be outside or what, I will put them on quarters because some of these patients can barely even function that day. And once you get the anti-inflammatory on board, they do a lot better. So I'm not saying get everybody quarters. I'm saying take the patient, okay, and look at the patient and assess these patients before you make a blanket statement of, I'm not doing that. Because that was me, I probably shouldn't have been, right? Probably not. And make sure that you understand that this affects patients differently. It affects patients differently. Some of these patients are super sensitive to these hormone changes, and so it's going to affect them differently. Most commonly for PMS, fatigue, bloating, labile mood, right? Fatigue, bloating, labile mood. So if you see that in a patient that's coming in to talk to you about their PMS syndrome, okay, or symptoms, and you see these words, then consider giving them, treating them, the anti-inflammatories. If you see something like this, something called premenstrual dysphoric disorder. Now these patients are still having those symptoms, headache, fatigue, bloating, but their symptoms are so severe, they can't even get out of bed. They've lost jobs because they can't go to work because they're so labile in their mood. They're so depressed, okay? And their symptoms really just encompass everything about them. I can't do anything for this period of time. Usually this is going to occur just before the menstrual cycle, so in the latter half of that luteal phase, okay? And there's going to be a time period of about 7 days, or at least 7 days, where they have no, I feel great, no problems at all. In other words, if they come in and they say, for the last 3 months, every single day I feel like this, well, maybe they're just moody, right? Maybe they just have significant depression. Maybe we should talk about that. These people that have PMDD, there's a period of time where they feel normal. They feel okay. They feel great, okay? But then there's a period of time, again, just before their menstrual cycle, where they can't do anything. They can't get out of bed. It significantly impacts. The thought process is for these patients, because it doesn't happen in a tremendous amount of our population. For these patients, they're super sensitive to those estrogen and progesterone changes. So estrogen and progesterone are neurosteroids of sort. Estrogen gives you that little bit of excitement, progesterone kind of a little bit of depression. So they're super sensitive to these changes from the neurosteroids, from the estrogen and the progesterone. Okay? There's a lot of these patients that have PMDD, they do have an underlying psychiatric disorder. They do have underlying depression. Maybe it's treated, maybe it's not. Maybe it's diagnosed, maybe it's not. Okay, but a lot of them have a real good overlay of psychiatric disease. Okay? People that have diets that are high in sugar, high in caffeine, also tend to have an increase in their symptoms. We talked to them about that. And there's no blood test that you can do. This is a DSM-5 diagnosis, and the criteria for this are kind of underlined in red. Okay, you've got to have, the symptoms that are, at least 5 or more symptoms that are occurring in that latter half of the luteal phase. You've got to have a period of time where they don't have the symptoms. Okay, they have complete recovery. So I would make sure you understand these diagnostic criteria. We'll see that again. And the other thing is we like to see this in at least 2 consecutive cycles. So if they come in month 1, we're gonna keep watching them. We're gonna keep watching for at least 2 consecutive cycles. This is purposely small because I don't want you to memorize this chart. What I want you to understand is sometimes it's hard to figure out when these symptoms are occurring. So we send these patients home with some sort of tracker. I want you to mark on here what days this is occurring. So that when they come back to see you in 2 or 3 months from now, all you have to do is hold up a paper and you're like, look, exactly what I thought. Lateral half of that luteal phase just before your menstrual period, this is what it is. Versus, I got a day here, I've got 3 days here, there's 2 days over here. That's not PMDD, that's something else that's causing that. So latter half of that luteal phase. What do we do for these patients? PMS, PMDD, we can give them anti-inflammatories. Okay, PMS, that's the primary treatment. Okay, for PMDD, it's an additional treatment, and that helps reduce the prostaglandins. Okay, we can give them diuretics if you want. How many women have a lot of bloating, have a lot of weight retained? But remember, these medications are not without risk. You put someone on an HCTZ, and that is a diuretic, what are they peeing out? Potassium, okay, peeing out potassium, their electrolytes. Okay, let's say they're big runners. They're out there running 15, 20 miles every other day. And now they're on this, they may come into you almost passing out from hypokalemia. So you gotta be careful. I'm not saying don't do it, just gotta know that there's always risk with these medications, and those are the risks you talk to your patients about as well. PMDD, primary treatment for PMD, SSRI. Okay, SSRI. Secondary, we can treat them with something like a combined oral contraceptive. That combined oral contraceptive helps kind of equal out those hormones, so we don't have those fluctuations in the hormones. Okay? Again, there's other agents you can use as well, but specifically for PMDD, we like combined oral contraceptive as kind of a primary, or one of our better contraceptives for treatment. Okay, we can use GnRH agonists like Lupulide or Lupon, but GnRH agonists have a lot of side effects. The main one is menopause. And I'm here to tell you, hey, you don't want to put nobody in menopause. And you do not want females walking around there. If all females walked around in menopause, this world would be a little bit different. Okay? So we don't want to do that unless we have no other option and don't respond to the SSRI. Okay? Then we can ultimately look into a GnRH agonist. And we talk about GnRH agonists quite a bit for several different things associated with female reproductive system. Danazol, again, kind of an older treatment. It's been danazol been around a long way. What else is danazol used for? You guys know? Malignant hypothermia? No. So poorly tolerated, and it causes people to start growing hair from different places. So in addition to menopause, we don't want hair growing out everywhere. So if we can control their symptoms with SSRIs, maybe a little anti-inflammatories, and then combined oral contraceptives, that combination tends to work pretty well for most folks. Decrease the amount of sugar and caffeine. You're talking about that. Okay. Calcium also tends to work by decreasing the amount of cramping they may have that's associated with dysmenorrhea or PMDD or the PMS. Okay. Pyridoxine, which is B6. We like pyridoxine in pregnancy. We like it here too, 50 to 100 milligrams a day. Okay, that kind of helps with their mood stability. Vitamin E helps as well. Sometimes increasing their exercise or having them exercise, acupuncture, those are other things that we can talk to our patients as well. When we think about vitamin E, we think that in association maybe with omega-3 fatty acids, and that helps reduce anxiety, helps reduce depression a little bit. You guys, one thing that we don't teach here is kind of holistic medicine. I think that would be a good little snippet for you guys to have. There's a lot of patients nowadays that come in and they want to know more about these supplements, but they don't have really a good grasp on supplements or a good class to talk to you guys on that. Anyway, so what do we do for these patients? Okay, we want to figure out, all right, when they're coming in, they've got that fatigue, they've got that bloating, they've got that mood instability. How significant is it? Okay, when is it occurring, and how much is it impacting the life? Are they able to get up, go to work, hang out with their friends, or are they like, I can't do any of those things? Like, I've lost friends, I've lost jobs, I've lost relationships because because of the severity of my symptom. Again, late luteal phase is when we're kind of thinking we gotta have 7 days where they have no symptoms at all. So you've gotta identify when it's occurring and make sure you identify if there's a period of time when you don't have symptoms. And treatment, SSRI is primarily gonna be for your PMDD, NSAIDs for PMS, and then for PMDD as an adjunct. And then we talked to them about those dietary changes. Alrighty, perfect, thank you.